Good evening, everyone, and welcome to 365 Live. I'm Bina, and I'll be your host for tonight. Just a gentle reminder that all information shared at this event by the speaker and 365 CPS is for general information only. Do consult your doctor for personalized and detailed medical advice. Without further ado, I'm pleased to introduce tonight's speaker, Dr. Chu Supin, medical oncologist at Curie Oncology. Dr. Chu specializes in gastrointestinal cancers, including colorectal, upper gastrointestinal, pancreatic, hepatobiliary, peritoneal, and anal cancers, with more than 20 years of experience. Tonight, she'll be sharing with us the potential causes of colorectal cancer and how we can reduce the risk of developing it. If you have any questions, please feel free to post them in the chat, and Dr. Chu will address your questions during the Q&A session. Hi, Dr. Chu. Thank you very much for joining us tonight
Hi.
to share your knowledge with everyone. I've read that colorectal cancer is one of the most common cancers in Singapore. I'm sure our audience is interested to find out more from tonight's session. So let me hand over the time to you now. Dr. Chu, please.
Hey, thank you very much, Bina, and thank you 365 for inviting me here today to share about colorectal cancer. I try and keep it interactive if possible. Please feel free to ask questions. And really, it's true, colorectal cancer is actually the most common cancer in Singapore if you look at men and women combined. Next slide. Sorry, I can't share my slides because I'm overseas due to some last-minute travel rearrangements, but can you forward? These are my disclosures. Next slide. Okay, so I will start off with common myths about colorectal cancer. According to ChatGPT, I mean, now we all use DeepSeek or ChatGPT or whatever, and they listed out these 6 common myths. And I hope that after this session, these myths will no longer be myths, at least in your eyes. Myth number 1 is that colorectal cancer only affects older people. I will show you that is not true anymore. You only need to get screened for colorectal cancer if you have symptoms. Actually, when you have symptoms, sometimes it's a little bit late already. In fact, it's one of the most preventable cancers that we have, okay? Colonoscopies. Myth number 3 is that colonoscopies are dangerous and painful. Actually, it's not. Most of the time, you're sleeping and you don't know what's happening, and you wake up, it's done. Myth number 4, if you don't have a family history of colorectal cancer, you don't need to worry. That's not true. Majority of our colorectal cancers have nothing to do with family history, what we call sporadic colorectal cancers. Myth number 5, colorectal cancer is a man's disease. I just told you, even for men and women combined, it's still the number 1 cancer. It's not number 1 for women because breast is number 1 for women, but it's number 2 for women if you just look at women alone. Myth number 6, colon cancer is always a death sentence. That's not true. In fact, even in stage 4 colon cancer, we've become more aggressive because our treatment has improved so much that even stage 4 cancers can be potentially curable in some cases. Next slide. So I just get to the basics first. What is colorectal cancer? It's a cancer of the large intestine, in which, as you can see that picture, it involves your colon, which is the cecum, the ascending colon, transverse colon, descending colon, sigmoid colon, which is the most common site of where colorectal cancers happen, and the sigmoid colon. And then your rectum as well, before it hits your anus, that's where your stools come out. And the function of the colon is when food enters the colon, water is absorbed, and then the food residue is converted into waste, which is your feces by bacteria. And the rectum is really the terminal part of the colon that stores the feces before it's expelled out through the anus. Next slide. So how does colorectal cancer develop? As I said, it's a very preventable cancer. Majority of colorectal cancers originate from polyps, which form in the inner wall of the colon of the rectum. And then they start off as polyps. Polyps are not cancers, they are benign lumps, fairly common in people above the age of 50, and also in some people who have predispositions to them. 10% of these polyps, not all polyps become cancer, but about 10% or so of these polyps can become cancer over time. It usually takes up to 10 years, 5 to 10 years to become cancer. So once you do a scope and you see a polyp is removed, then you don't have to. Then the worry about that polyp becoming cancer is gone essentially. Next slide. Yeah. So it's the third most common cancer worldwide, but it's the top cancer in Singapore. You can see the numbers here. The most common uh, type of colorectal cancer is adenocarcinoma. Colorectal cancer is, you can see here in the list, if you look at this Singapore statistics, top 10 for men would be colorectal cancer number one. It used to be lung, but now lung is number two, and then you have prostate. If you look at women, breast, of course, is number one, but then number two is colorectal cancer, followed by lung. In terms of causes of cancer death, colorectal cancer would be the set number two for males and third for females because of how common it is. Next slide, please. So this is a trend in Singapore of colorectal cancers in both men and women. It's sort of stabilized in terms of the incidence, but majority, as I said, 80 to 90% of colorectal cancers are sporadic. That means there's no clear family history, there's no clear genetic risk. About 10 to 20% of colorectal cancers are related to genetic risk. That means you inherited a gene that predisposed you to getting the cancer. But the good news is that survival among colorectal cancer patients has increased over the years. You can see here due to better detection, earlier detection, and also better treatment options. So the question is, who is at risk of developing colorectal cancer? Common risk factors include age, right? So everyone's at risk for sure. Okay, the risk increases with age, especially those over 50 if you have normal risk. Of course, people with family history, close relatives like a parent or a sibling with colorectal cancer, that increases your risk. Lifestyle choices like lack of physical activity, smoking, excessive alcohol use are all also risk factors for developing colorectal cancer. So we always ask, why did I get cancer? I don't smoke, I don't drink. I have a fairly active lifestyle. Sometimes it's not just the lifestyle itself, it's genetic conditions. Hereditary, as I said, one of the most common is something called Lynch syndrome or familial adenomatous polyposis. And then the risk of colorectal cancer can start very young in the 20s. You can see that picture of the colon on the right, the whole colon is just studded with polyps. Usually these patients, we recommend total colectomy. That means you chop out the entire colon when they are in their sometime when they are in their 20s, because we know the risk of developing cancer is 90 over percent, okay, in their lifetime. So what we do in prevention is to really remove the entire colon. You can survive without that, but it's just that obviously the bowel movements will be very different from someone with a fully intact colon. Other risk factors include previous history of inflammatory bowel disease like Crohn's disease and ulcerative colitis. Any history of colon cancer, of course, even if cured, increases the risk of another episode of colon cancer. And I said before, any family history of colon cancer, even if we do not know a specific gene that's related to that family. Yeah, I said already, in Singapore context, if you're Chinese, you're higher risk than the other races. As I mentioned earlier, sedentary lifestyle, and of course the diet that's high in fatty foods, highly processed foods like bacon, um, uh, smoke things that are smoked, um, barbecue. These are all foods that are related, not cause and effect, but increases. If you have a diet high in this kind of unhealthy foods, the risk is higher than someone who's eats very healthily with fresh produce and more fruits and vegetables. Obesity is linked to all cancers, including colorectal cancer. So what we are observing across the entire globe is young onset colorectal cancer. Okay, as rising, basically is colorectal cancer in individuals who are less than 50 years old. Okay, and the number of these patients are increasing, not just in Singapore, in the US, in the developed world, we're seeing this trend, even in China. So, colorectal cancer is really the number one cause of cancer death among young women, and said the second leading cause of cancer death among young young women, sorry, and first in young men, can see that breast is still up there for females, but colorectal cancer, you can see the trend increasing among the young. Young meaning those less than 50 years old. Next, please. There are some differences between young onset colorectal cancers versus the rest of the usual older age group onset colorectal cancers. For example, this is American data. This is from Dana-Farber in Boston. The young patients are more likely to be or Black or African American. This is in American context. They're more likely to be normal weight, more likely to be never smokers, more likely to present at advanced disease. And that's because, when young patients complain about like bleeding in stools or stomach pain, doctors tend to say, nah, it can't be cancer, and try and rule out all the other possibilities first, and they often diagnose late. Also, young patients may present to the doctor at a later stage thinking, oh, the bleeding is just piles. Okay. Also, young patients have tumors that are what we call more likely to have poor differentiation, which may be a bit more aggressive. Next slide, please. So you can see this a survey. This was an American survey on 1,000 patients with young onset colorectal cancer, and you can see there's a lot of delay in diagnosis. 41% waited more than 6 months before seeking medical attention. 67% saw 2 or more physicians before finally getting to a diagnosis, and about 70%, which is very high, were diagnosed with stage 3 or 4 disease at the point of knowing that they had cancer. Next slide, please. So we have beginning to recognize the last few years, a lot of focus on young onset colon cancers because they do face unique challenges. Many would face anxiety, depression. I mean, when you're young, of course, many have young children as well. They're still in the productive years of their life. So that has a lot of direct impact on their families, on their self-esteem as well. And really, there are a lot of needs in terms of job, schooling, and things like that that are a bit different from the patients who are usually who are the non-young colorectal cancer patients who tend to discover their cancer when they are 70, 80 years old and already in retirement mode. So this is also been recognized in Singapore. You can see this newspaper article in Straits Times a while back, talking about uptick in colon cancer rates among people under 50. And then there's been a lot of debate about whether our colon cancer screening age should be dropped down to 45. In the US, the age for the normal risk average risk adult is 45 years old, but in Singapore it's still 50 years old. For various reasons, ministry hasn't changed the cutoff age yet, though this has been debated many times. Okay, for cost effectiveness reasons. There's been linked to suggest, obviously, as I mentioned, processed foods and cancer and things like, and we think that this young onset is largely due to lifestyle reasons, though of course we cannot rule out environmental reasons which are not so clear to us. Yeah, next slide, please. So let's go talk about basics about what colorectal cancer is and what are the potential symptoms. In the early stages, there may not be any symptoms at all. Okay, we always see this, I don't feel anything, how come I got cancer, right? It can happen. But typical bad, what we call red flag signs would be change in bowel habits. That means, let's say you pass motion once a day, right? And that's your normal for many, many years. And suddenly you start having diarrhea, constipation, it's all over a place and it's persistent. It's not like diarrhea, food poisoning for a few days. diarrhea for weeks on end, or suddenly you cannot pass motion, having very bad constipation. And this has never been the case. This is what we call change in bowel habits. Change in the stool caliber, like it used to be firm, soft stool, then it becomes very, very watery or becomes extremely hard for a persistent period of time. Those are warning signs as well. Presence of blood or mucus mixed inside the stool especially is not a good sign. It's a bit different from piles. Piles, usually the stool is normal brown in color, but after the stool comes out, then blood drips into the toilet bowl. That's usually typically piles, right? When it's colon cancer, the blood is mixed inside with the stool. Other symptoms may be persistent abdominal discomfort, cramps, gas, especially after eating, and perhaps pain. Some people may feel a mass in the abdomen, or there's unexplained appetite loss and weight loss. Can the cancer be prevented? You cannot stop mutations and cancer cells from forming, but you can reduce your risk of developing cancer, and you can screen. Next slide, please. Okay, and this is Singapore Cancer Society's screening services, and I think 365 also has their own. Next, please. And screening for colon cancer has been available in Singapore for years. Singapore Cancer Society has always been giving out the free fecal occult blood kits to people who are 50 years old and above for many, many years. But our screening rates are still very low. It's only 20%. Okay, and I don't have one answer why our screening rates are low. Is there a lack of awareness? There have been both Singapore Cancer Society, 365, and many other, all the cancer centers have done a lot of efforts to do colorectal cancer awareness, and increase awareness among the general public. But I think a lot of you just feel that if they are well, there's no need to screen. And I think this thinking needs to be changed. Next slide. So screening recommendations for average risk individual is really 50 years old, at least in the Singapore guidelines at the moment. Though some of us may argue that maybe you should start at 45 because we're seeing a lot more young onset colon cancers. It can be a simple fecal occult blood test, which I'll talk about in a bit, which can be done yearly, or a colonoscopy or sigmoidoscopy can be done every 5 to 10 years. Those who are high risk group should be screened earlier and more frequently. So if you're high risk, that's a completely different algorithm, and it's not straightforward. It's very complicated depending on whether you're Lynch syndrome, whether you're FAP, and if you're Lynch syndrome, whether you have MLH1 loss, whether you have MSH2 loss. The screening is a bit different, and many of these families that have this genetic risk is not just screening for colon cancer, they also have to screen for other cancers. Okay, but for general population, it's really just 50 years and above. And as I said, the polyps can be removed. That's why usually I prefer a scope at some point to look for polyps because they can be removed on the spot. So this just shows you the different risk groups and what they need to do versus the average risk. If you're high risk, the screening is a lot different from patients who are normal risk, and it gets a little more complicated. Usually you need someone who understands all the algorithms and a doctor who knows all this stuff, who can advise. Next slide, please. So fecal occult blood test is just looking for blood in the stools. It can be a first sign of polyps or cancer, but also hard to differentiate. If you have piles, your stool, fecal occult blood test may be positive, as well. If you have food poisoning, there might be blood in your stool as well. Okay, and these kits are usually available at any GP clinic. Next slide. You basically just collect your stool and put it in this tube and send it to the lab. So this is what it looks like. The whole process of taking a sample of your stool and then just putting a tube and sending it off. Okay, so if your fecal occult blood test is positive, you will still need further colonoscopy. Next, please. So this is a colonoscopy and flexible sigmoidoscopy. So colonoscopy goes all the way through the entire colon, all the way to the cecum, which is just before it becomes the small intestine. While flex sigmoidoscopy only goes all the way up to the sigmoid colon and the descending colon, because that's where the most majority of colon cancers happen. Okay, next slide, please. And there's a picture of how during the scope, polyp can be removed just by using a snare. Okay. So besides screening, what can you do to reduce your risk? You need to know your risk profile first. Okay, if you're a high risk profile, then you walk a different route from someone who's average risk. But for general, everybody, I think lifestyle is number one. Eating a variety of fruits, vegetables, whole grains. Really try not to drink alcohol if you can. If you want to, now alcohol, is carcinogen. It's been finally, after many years, the US Surgeon General has labeled it a carcinogen. Um, if you can not drink at all, it would be the best rather than moderation. You shouldn't smoke. You should exercise regularly, and that means at least 30 minutes of exercise on most days, and maintain a healthy weight. There is some discussion about whether some people with very high risk of developing colon cancers may benefit from aspirin. Usually, these are for people who have genetic risk. Next slide, please. But there's no magic potion, for cancer prevention. Sometimes you do everything right, but you still kena the cancer, unfortunately. Next slide, please. So what is colon cancer? There are 4 stages of colorectal cancer, just like most other cancers: stage 1, stage 2, stage 3, stage 4. And it depends on the depth of the tumor and whether it's spread to the lymph nodes, regional lymph nodes, which is the lymph nodes around the colon, or whether it's spread to other organs. Next slide, please. So surgery is the main curative therapy for colorectal cancer. Most colon cancers, if detected early, stage 1, stage 2, stage 3, are all amenable to surgery. Even stage 4, in selective cases, we can still render cure with surgery if the spread is only to one organ. Of course, if the spread is to multiple organs, bone, liver, lungs, all over the place, then usually we don't talk about cure, we don't talk about surgery. Next slide, please. So what typically happens in earlier stage colon cancers is the surgeon removes the cancer. We send it to the lab. The pathologist examines the resected cancer, and that tells us the exact stage of the cancer, whether the lymph nodes are involved, whether how deep the tumor is microscopically. Then we decide whether or not adjuvant chemotherapy to prevent the cancer from coming back is required. So generally, early stage 1 colon cancers, we don't give adjuvant chemo. But stage 3, we do offer chemo for everybody. Stage 2, only in the high-risk subgroups. Next slide, please. So these are pictorial pictures of how surgery is done depending on where the tumor is. So the right side, we do a right hemicolectomy, half the right colon's removed. Left side, then we do sometimes left hemicolectomy or something a bit less smaller depending on where the site is. Next, please. So open surgery wound looks like that. Well, now most surgeons do laparoscopic surgery, and then you have a very tiny scar. So what other therapies do we use? We use chemotherapy, mostly in the early setting. We do add targeted therapies with drugs which block parts of the cancer pathway, like bevacizumab, cetuximab, panitumumab, even Herceptin. But these targeted therapies are usually used in the advanced setting. Immunotherapy has been like the big thing in the news, and everybody was asking us about immunotherapy, but honestly, only for a very small subgroup of colorectal cancers who are super sensitive to immunotherapy. These are colorectal cancers that have microsatellite instability. That's only about 10% of colorectal cancers. 90% of colorectal cancers do not respond to immunotherapy because they do not have the microsatellite instability. But there was in the news, especially in New York Times and Straits Times, even it was all over the place. Oh, immunotherapy cures rectal cancer, because in this subgroup of rectal cancer patients who have this thing called microsatellite instability, they responded to immunotherapy. 100% of the patients responded, and there was no need for them to undergo chemo, radiation, and surgery. That's why it was big news, because it changed the whole idea of how to treat this group of patients who in the past would have received chemo, radiation, and surgery. Okay, now these patients just had immunotherapy and the cancers disappeared. But this is not for most people. Majority of the cancers we see, unfortunately, are not sensitive to immunotherapy. Radiation therapy is still used for local control, especially for rectal cancers that tend to recur locally, but not so for colon cancers, unless it is for palliation in a metastatic setting. Stem cell therapy and other alternatives are really not proven at all, though we are asked this all the time. Next slide, please. So some other facts about colorectal cancer. This is based on questions that we get asked all the time from people. CEA, which is a cancer marker, is not a screening tool, though it's often used in all your executive healthcare screening packages. It is not accurate. Normal CAA does not mean no cancer. In the same way, a high CAA does not mean there is cancer. That's how inaccurate the test is. But it's unfortunately part of all the executive healthcare screening packages, and we lost this fight 20-something years ago when we tried to tell the GP world not to use CA as a screening tool, but we failed. Okay, but nevertheless, it is useful for us. We do use it in the oncology clinic to monitor response or to look for cancer recurrence in colorectal cancer patients. Okay. Staging of colorectal cancer really depends on the depth of the tumor, what we call the T for how deep the tumor is invading into the colon. Also, it depends on whether lymph nodes around the colon have been affected, what's called the N, and then the M, whether it's spread outside the large intestine to another organ, metastasized, M for metastasis. Okay, and then as I said, treatment depends on the stage. Every patient's cancer is different. So a stage 1 colon cancer patient is very different from a stage 4. Even among stage 4 cancer patients, whether you have certain molecular, I'll talk about that later, where the location is, the treatment differs. Okay, outcome of treatment really depends. So there are certain molecular subgroups of colon cancer, like the BRAF mutant colorectal cancers, that tend to do very badly because they are very aggressive cancers and they don't respond well to most treatments. So this is just to show you the T staging. I won't go into that. This is a breakdown. That's how we stage our cancers. Next slide. The N staging part, how many lymph nodes, which lymph nodes. So we need to know the anatomy. Next slide. And this is just a snapshot of 5-year overall survival of colon cancers. Stage 1 is very good, 90% are cured. So 5 years, when you hit 5 years, no cancer, you're considered cured for colorectal cancer. Because most cancers will relapse within the first 2 years if they do. After 5 years, the chance of relapse is almost next to nil. Okay. If you have another colon cancer after 5 years, it's usually a new event. It's not related to the first time the colon cancer was diagnosed. So stage 1 is like 90% cure rate, whilst in stage 4, of course, that drops down to 5% or so. Yeah. But in some stages where we can remove the metastasis, we can still get cure in up to 40 to 50% of patients. But these are a selected group of patients. Next slide, please. So this shows a diagram of how cancer can spread, usually through the bloodstream or through lymphatic system, which is all your lymph nodes, which are like the branches of a tree, and then they can spread to the lungs, the liver. Liver is a favorite spot for colon cancer, peritoneum, and other places. Okay, so stage 4 essentially implies it's spread out. Okay, so just a picture of liver. You can see multiple spots in the liver. The dark spots are cancer. And then you can see this chest x-ray of the lung. Multiple white fluffy shadows. That's lung metastasis, and it's what we call cannonball lesions. Okay, and 80% of colon cancers, if they metastasize, will go to the liver. Next slide, please. Basically the treatment in stage 4, really we talk about first line, second line, third line, fourth line, fifth line, and so on. And basically we want to get patients through as much therapy as possible, because this leads to prolongation of survival. Okay, and but patients do drop off. At the first line, maybe 100% of patients will be able to receive treatment. But after that, some patients become so unfit they cannot receive the second line of treatment, and so on. Really depends on the patient's stage and their physical fitness and so on. So this is our treatment over the years. When I first started oncology, I can tell you that, we had just started biologics, which is the second. We had chemotherapy already for a long time, since the 70s, and biologics was just coming onto the market. Okay, but now obviously we have evolved. Colorectal cancer has become more complicated. In the old days, it was very easy. You can treat every cancer, all the same chemo. But now colorectal cancer is now broken down to multiple subtypes and subgroups based on molecular profiling. That's why we subspecialize nowadays, not like the old days. Old days, you can one oncologist can treat any cancer. It doesn't make a difference, because the chemo all about the same. But now it's not so. But the good news is that, of course, survival has improved significantly, especially for the microsatellite unstable colorectal cancers. Okay, this just shows a snapshot. Okay, so this just shows the treatment guidelines for colorectal cancer, and I just wanted to show how this is just stage 4. I'm not talking about stage 2, stage 3, and all that. This is stage 4. Just look at this chart. Basically, this first line treatment only, not second, third, or fourth line. And you can see that we subdivide our colorectal cancers based on whether they have certain molecular profiles, whether you have a RAS wild type, whether you're BRAF wild type, RAS mutant, BRAF mutant, MSI high. Further on, there's HER2 and so on. And this is where we're heading with all these cancers, but a bit more complicated, but also better in terms of patient outcome. So at the end of the day, there is the treatment of colorectal cancer requires multiple doctors. It's not just a surgeon alone. It's not just an oncologist alone. We really work in a multidisciplinary team, because sometimes it requires the radiologist to look at the images, requires the pathologist to give us specific answers, and otherwise to decide on the best optimal outcome for each patient. So it's not so straightforward. So this is molecular testing is the standard of care now for all our colorectal cancers. At the point of diagnosis, we test for all these subgroups, because this helps us determine treatment. So in terms of stages of cancer in Singapore, we have about 23% of colon cancer patients are stage 4 at diagnosis. We are not that bad. Used to be 70%. We definitely improved. And even for stage 4 patients, our survival is about 3 years, 2 to 3 years on average. So this is improving. I think very soon, with the recent therapies, we're going to hit 3 to 4 years. Next, please. So I'll just go into that's all I wanted to say about colon cancer as a whole. I'm going to answer some frequently asked questions. Okay, I have piles. Will they turn into cancer? The answer is no. If there's blood and stool, should I go for a stool test? Well, you should go and see a doctor first to discuss what this blood and stool is, because there are many types, reasons for blood and stool. How often should I go for colonoscopies? Depending on your earlier scopes. So, for example, at 50 years old, if you do a scope and we find a polyp, right? Yeah, usually if you don't find anything, usually the doctor will say, okay, your next scope is 5 years from now. But you find a polyp, and the polyp is of concern, and it's removed at that scope, the doctor is likely to say, no, you need to repeat your scope in 2 years' time. You cannot wait 5 years. Okay. If my family member has colon cancer, will I get colon cancer too? No, you cannot spread, but you may have increased risks of colorectal cancer, as I said before, due to genetic factors. Is colonoscopy dangerous? I hope I've told you that it's not. Okay. Okay, so this is my question to you guys. How old must you be before we start screening for colorectal cancer? I hope I gave you answer already. And can someone name me the risk factors for colorectal cancer? I don't know whether Bina, you want to take this.
Hi, Dr. Chu.
Yeah.
Based on your top, the guidelines currently state 50 years old, but
Yeah.
you mentioned that you would recommend from 45 onwards since there's a trend, right, with more people getting diagnosed at earlier age.
Yeah.
Yep, and then
Yeah.
yeah,
Very good.
Shan
People
got
are
it
saying
right too.
smoking, red meat, old age, obesity. Yay! Everyone's listening. 50 years old. Official answer is 50 years old in Singapore context. Unfortunately, I don't think you can use your shield plan to do all this screening. We all can answer that better. Yeah. We've been pushing the insurers to include screening uh, to cover for screening, but there's still a lot of resistance. Yeah.
Mm,
Yes,
yeah,
and
yeah, I
alcohol
see.
sedentary lifestyle, correct.
Nice.
Okay,
Everyone has been paying attention.
yeah, great. Okay, next slide. Want to move on? So I just tell you the biggest breakthrough. I mentioned immunotherapy, but immunotherapy actually means a lot of things. It's not just immunotherapy is not one therapy. It's actually multiple different types of therapy. And the one that has been the game changer for MSI high colorectal cancers is immune checkpoint inhibitors. Okay, which are drugs that stimulate the immune system to do its job of getting rid of the cancer cells by waking up the T cells that have what we call exhausted. There's also CAR T cell therapy, but that's really for blood cancers. Is not ready for prime time for colorectal cancers, though there are a lot of clinical trials going on. Then there's also NK cell therapy, dendritic cell therapy, stem cell. All these are not proven to work yet in cancer. Okay, but there are these centers. I sometimes I get patients ask, some center in Malaysia or what that can do NK cell therapy, dendritic cell, stem cell therapy, can treat cancer, can treat diabetes, can treat arthritis. When one treatment can treat every disease under the sun, I would be very suspicious. Okay. Okay. So I also wanted to touch on because these are questions I face every day about diet and all this, and what can prevent cancer, and the internet is mind-boggling. Like you type anti-cancer food, anti-cancer treatment, alternative. There are thousands and millions of pages telling you this, that, and the other. A lot of it is very half truths, not always not true, but a lot of half truths and not the full picture. So really, the reality facing us is there's tons of literature out there. There's a lot of hearsay, waiting room advice, old wives' tale, well-meaning friends, folks recommending this herb, that supplement, this leaf, that drink. Okay, what's the truth? Where are the firm answers? How can we be more discerning? How can we advise our patients, our relatives, and our friends? Okay, if we listen to everything out there, we'll be like this picture here. There's nothing to eat. The fridge is full of food, but everything is dangerous. Yeah. So there are a lot of common myths about supplements. The more is better myth. Natural is safe, but natural is better. But uh, it's been used for thousands of years, so it must be good. It can't hurt to take supplements along with regular medicines. I would be cautious about that. Always check with your own doctor. Um, the chemo that we use called Taxol or taxanes, docetaxel, actually comes from the bark of the yew tree. Natural chemo, but it's very toxic. That's why you use it to treat cancers. So natural doesn't always mean safe. So the other common myth is about sugar feeding cancer. We get this all the time. Okay, but the fact is all your cells in your body need sugar for energy, and sugar comes from all kinds of food. It's not like sugar is has got this sensor that goes in your body and goes to only like feed the cancer cell. How about your normal cells? You need a, a balanced, healthy diet, fully nourished. I'm not asking you to eat 1 kg of sugar or drink soda pop every day, and it's not healthy. Okay. But if you obviously eat too much sugar, become obese, then of course that's not a good thing. But sugar feeding cancer is very simplistic thinking. Okay. So other common myths that CT scans are harmful, but honestly the risk is very, very low, and sometimes you need the CT because that really helps you. Is essential to determine that disease, whether there's disease or not, or determine what to do about disease. Next slide. I think that was it. Third stop here, and open up for you guys to ask questions, possible.
Thanks, Dr. Chu. So if anyone has any questions, please feel free to share them in the comments, and then Dr. Chu will help to address them. So we have one question from Jill. So what is the average cost for colon cancer treatment?
Depends on whether it's in government or private.
I guess
Government is
maybe
heavily
government.
subsidized.
Mm,
So yeah, so government is heavily subsidized. So if you're C class, you're just paying like 30%. You can use your MediShield, MediSave, and then there's MediFund and all that.
mm,
It's not is good. If you need MediFund, you're never going to be deprived of treatment, even if you
mm,
can't pay. Basically, at least basic treatment, right? But of course, if you're going private, whether it's in government or private, of course the cost will increase, depending on. And how do you say average cost? It's impossible to say average cost because a stage 4 cancer is very different from a stage 1. Stage 1 just operate, pay for surgery, and that's it.
mm.
A stage 4, you have 1 line, 2 lines, 3 lines. If you need immunotherapy, then the cost escalates into the thousands and tens of thousands. Yeah.
Mm.
So what are the common chemotherapy agents for colorectal cancers? 5-fluorouracil, oxaliplatin, irinotecan. These are the 3 most common chemotherapy drugs that we use. Yeah.
So we have a question from Shan Chan. So what is considered healthy stools?
Brown, yellow form stools, soft form stools. Not too hard, not too soft. No.
When is a good frequency for your
I think everyone's different. I think it's what
mm,
some people normal to them is once every 2-3 days.
mm,
So everyone's different, right? You have friends who poop once every 2 days, and that's normal for them because they've been doing it for
mm,
years. But some
mm.
people is twice a day, that's their normal. There's some people
Okay.
it's 3 times a day. So it really depends on what is your regular pattern for years. Yeah.
So there's no like fixed frequency, but then if we
No,
notice
it
like a
depends.
change in the frequency
Yes,
and
it's the change that
mm,
what you're looking out for. Yeah.
okay. So I have a question for you. Like you mentioned that during the colonoscopy, then you will be able to detect polyps, right? Is that the only way we can detect polyps? Is there like any
No,
biomarkers we can check?
there's also CT colonogram.
Mm,
But not very popular because you still need to stick something up the butt,
mm,
and you need to go through a CT scan, but it's less
okay.
invasive, lah. You don't scoping. Yeah.
Mm,
But if a CT colonogram shows up a polyp, you still need to go scope to remove it. So
oh, okay.
yeah, it's less invasive potentially, but if you find something, you still need to go through a scope. Yeah.
So it's like more convenient to do a colonoscopy because like when you are like
I think
detecting it,
I
you can
think
remove.
yeah, but it's just a different method of
Mm,
detecting polyps
mm,
or lumps in the colon.
mm,
Yeah, without sticking something
mm,
a tube up the butt lah. They just need
mm,
to put
mm,
an animal up the butt lah. That's it.
mm. And
Yeah.
you mentioned like if polyps were detected and removed, then the doctor will usually recommend the patient to come back for another like scope with like around 2 years, right? So is it
Yeah.
because there's a risk of the polyps growing back after you cut?
Yeah. So there's once you have polyps, then the risk of having polyps again is higher. So usually they'll be
Mm.
recommend a closer interval for scopes. Yeah.
Okay, nice. Thank you. Let me see. So we have a audience member, Cass, who did their colonoscopy in January. Everything was fine, but this month there's some pain in the stomach. So is it recommended for them to go to like a CT
I can't
scan?
answer this because it depends on what your pain is, your risk profile, your age, any other medical problems and all that. It's best to consult a doctor
Mm,
to discuss this, whether or not you need to go for a scan and how long your pain is, what's the nature of the pain, what's the frequency and so on. Yeah.
mm. Thanks. There's also, yes, a question. What are some of the early warning signs we should be aware of if we are perfectly fine and healthy?
I think I mentioned blood in stools, mixed with
Mm,
stools, mucus in stool. Those are not good
Is
signs.
that the
Change in bowel
main?
habits,
Mm,
um, unexplained weight loss. These are these are not good signs at all. Yeah.
mm. How long must they like persist before we seek medical attention? Because like sometimes it might just happen like 1 or 2 days, within that week. But like how long should we like start being very concerned?
I think if it's like if say a few days you have food poisoning, vomited, fever, and then there's blood in the stool, I think, and then it stops. There's nothing to worry. I think persistent is the issue. Like one
Mm,
week, 2 weeks. If you have bleeding in the stool for a couple of weeks, more than 2 weeks, I think it's something's not right, right? If it's not
mm,
pulse, yeah.
okay, thank you. Okay. Is it advisable to take probiotic supplements? Is that something that your patients would also
So
ask?
it helps a lot of people in terms of digestion.
Mm,
There's some data to suggest that it helps your gut microbiome, which
mm,
is good for general health, not just anti-cancer or anti-colon cancer. But the problem we have now is we're not sure what's the best probiotic. There's so many in the market. Okay.
mm,
There's data for some being better than others. For example, there's data for something called echinacea, which is not so common here, but that's based on a couple of studies, right? So really, probiotic, yes, probably has some health benefits, but I'm not sure which one's the best one to take.
mm.
I don't think anyone knows. Yeah.
Yeah.
But it's more like people take it because they feel, oh, it helps in my digestion. I used to have a lot of gastric irritation, irritable stomach.
Mm,
It helps me now. Yeah.
mm. Nice. Thanks, Dr. Chu. So Jill has a question. So assuming that somebody has stage 2 colon cancer, so how much would the treatment cost be?
I think you have to consult the doctors, whichever, whether it's private. It's very hard to give you a estimate of how much it will cost, honestly,
Mm,
because it depends on whether you need chemo or don't need chemo. Some stage twos don't need chemo, just surgery.
mm,
Some stage twos need chemo. Yeah. Some need more chemo than others.
True. Thanks. And then Chan Chan has a question. So what does mucus in stools mean? So I guess if like blood,
Inside the
you can see
stool,
like
you
red,
see like
right?
this slimy stuff like mucus from like teeth, from
Oh, okay.
mucus from your nose, but in the stool. That's what we mean, yeah.
Okay. So it will be quite a significant amount, or must people like really investigate their stool to
Yeah.
detect that?
Prevent polyps, I think it's just lifestyle changes because um, whether or not some people can, I think more importantly is screening for polyps rather than preventing polyps. Yeah.
Mm. So
Sometimes
I
polyps just happen. Mm.
okay.
And as I said, not all polyps become cancer.
Mm,
So
only
yeah,
10%, right?
yeah.
So there was this hereditary condition that you mentioned, like the entire
Lynch
colon.
syndrome. Oh,
Yes,
FAP. Yeah, the
yes.
entire colon is full just polyps. So those
How would
patients usually they get the entire colon removed, operated out.
how would people know that they have such a condition? Like, are there other symptoms that they would?
Usually the family history very strong.
Mm,
Multiple generations with colon cancer.
okay.
Yeah.
Uh, so you
Then we have to
mentioned
go and test. So
ah,
once these patients usually there's a family history. Family history doesn't mean then we see a pattern, right? Or they
mm,
have very young onset colon cancer. Anyone with young onset colon cancer, immediately we talk about genetic testing, even if
mm,
there's no family history. Because nowadays families are very small. We may have skipped
mm,
a couple of generations, right? No
mm,
longer 20,
mm.
20 grandma had 20 kids, but the generation maybe one child or two children only. So you may not see the pattern so clearly.
Mm,
Then we do the genetic test is usually a blood test. We take the
mm,
blood, we send off and do send to a reputable lab that does the testing, and they will look for a panel of genes that we know of that predispose people to colorectal cancer. Um, and like whether it's Lynch syndrome is more common than FAP.
mm,
And we see patterns in usually if you dig hard enough, you see family history. There's ovarian cancer, breast cancer, prostate cancer. They're male, colon cancer. It may not be only just colon cancer.
mm,
And once we find that patients have Lynch syndrome, then even after we treat the cancer, let's say the cancer is detected early, is treated already, they still have to screen for other types of cancers. And then let's say they have siblings or cousins or nephews or nieces, then we have to offer testing to the rest of the family. And then
mm,
whoever's positive who has not had cancer before, their screening starts way earlier than average Joe. Yeah.
mm. So I think on this topic of testing for mutations and stuff like that, or like genetic conditions, you mentioned that for some of the cancers, there will be like benefit for like certain subgroups if they have certain mutations or like microsatellite instability. So when
Mm.
would the doctor suggest the patient to take such a test?
Microsatellite instability is tested on the cancer itself, not in the blood.
Mm,
Okay, so when the tumor is biopsy, we usually will test straight away. One of the
okay.
standard tests nowadays. Yeah.
Okay. I think that's all that we have for tonight. So thank you, Dr. Chu, and thank you everyone for your questions. So it's now time for Dr. Chu to take her leave. Once again, thank you very much for sharing your time tonight.
Yeah, welcome. Hope everyone has learned something. Thank you very much. Bye.
Thank you. Bye. Do like, share, and follow us on our social media pages for the latest updates on our events. Once again, thank you very much for joining us tonight. I hope to see you all in the next section. Take care, stay healthy, and good night.